The patient with a disability. Disabilities overview. This chapter provides general guidelines for modifying dental hygiene care for a patient with a disability. People with disabilities may require a modified approach to oral health care in order to achieve and maintain oral health and prevent rampant dental caries. An estimated 10.5% of individuals aged 17 to 64 years, 5.4% of children aged 5 to 17 years, and 35.4% of people aged above 65 years are affected by a disability, and the number is increasing. The Americans with Disability Act, ADA, defines 54 million individuals as disabled, including 1 million children below 6 years of age and 4.5 million between 6 and 16 years of age. Progress in medical care has increased initial survival of those born with a disability and increased the survival rate of those experiencing a disabling condition. Advances in medicine have increased the lifespan of people with comorbidities that would have shortened their lifespans. As life expectancy increases, so does the likelihood of acquiring a disability. Individuals with disabilities often have less access to oral health services due to challenges for the patient, caregiver, and the dental personnel. The patient may need to overcome numerous obstacles in daily living before the additional issues of oral self-care and access to dental care are addressed. Imagination, ingenuity, flexibility, persistence, and patience are necessary in order to individualize and modify dental hygiene interventions when caring for people with disabilities. Successful management and treatment of patients depends largely on the interpersonal communication between the patient and the clinician. Services are provided in a manner that makes people less different and focuses on the needs of the individuals and not their differences. Americans with Disability Act, the purpose. The ADA is civil rights legislation enacted into law on July the 26th of 1990 that prohibits discrimination and guarantee that people with disabilities have the same opportunities as everyone else to participate in the mainstream of American life, to enjoy including employment opportunities, to purchase goods and services, and to participate in state and local government programs and services. The definition. ADA defines an individual with a disability as a person who has a physical or mental impairment that substantially limits one or more major life activities, has a record of such impairment, is regarded as having such an impairment. Major life activities include, but are not limited to, caring for oneself, performing manual tasks, seeing, hearing, eating, sleeping, walking, standing, lifting, bending, speaking, breathing, learning, reading, concentrating, thinking, communicating, and working. Definitions and classifications. Disability is an umbrella term for impairment, activity limitations, and participation restrictions. Impairment refers to a problem with body structure or function. Disabling condition can be developmental, communicative, medical, musculoskeletal, neurological, or sensory. Activity limitations is when an individual has difficulty in executing a task associated with daily living. Participation restrictions is when an individual has a problem involving a life situation. The term handicap is no longer used as it implies an individual with impairment is disadvantaged. Person-first language is important to emphasize the person and not the disability. The disability is not a defining characteristic of an individual, but rather part of the whole person. For example, avoid saying disabled child. Instead, use child with a disability. Types of conditions. Types of disabilities include developmental, hereditary conditions that manifest symptoms before age 21, acquired or caused by chronic disease, acute medical conditions, or trauma. Age-associated usually occur after 65 years of age and often related to chronic health conditions. Some types of impairment can manifest as a stable condition. Others may cause progressive disability. A temporary disability can result from a physical impairment such as a broken leg or because of a physiological condition such as limitations that may occur during pregnancy. A variety of impairments are found among persons with disabilities, and an individual may have more than one type of disability. Many diseases and syndromes with associated symptoms of disability or impairment are described in various chapters throughout this book. Physical and intellectual disabilities. Specific physical disabilities are described more in a different chapter, and neurological developmental disorders are also described in a different chapter. Sensory disabilities. Sensory disabilities are impairments of one of those senses: vision, hearing, touch, smell, and spatial awareness. When a patient has either a vision or hearing impairment, modifications to dental hygiene process of care, especially communication, is essential. Visual impairment. There are an estimated 285 million individuals worldwide who have a visual impairment, with 39 million blind and 246 million with low vision. 23.7 Americans adults report have vision loss. Limitations of sight cover a broad spectrum from the slightly affected to completely blind with no perception of light. Blindness may be secondary to another primary condition or chronic disease. Legal blindness is defined as having central vision or acuity of not more than 20/200 in the better eye with correction glasses, or having peripheral field side vision of no more than 20 degrees diameter. Individuals with visual impairment may use a white cane to aid them while walking and for identification purposes. Technology and assistive devices available for the visual impaired include computer screen readers that allow the individual to read displayed data with a speech synthesizer. Screen magnifiers are available to help the low vision user by enlarging the text and graphics on the screen. Braille, wristwatches, and printers. Causes of visual impairment. The leading age-related cause of blindness are diabetic retinopathy, macular degeneration, cataracts, glaucoma, trauma, and infection. In individuals above the age of 60 years, the leading cause of blindness is macular degeneration, which affects the viewing of the fine details and can interfere with reading, driving, and performing daily tasks. Blindness in children is of prenatal origin, resulting from maternal infections such as rubella, syphilis, and toxoplasmosis. Other causes in childhood are neoplasms and retinopathy prematurity. The incidence of retinopathy and prematurity has increased as more premature babies survive. Major causes of unilateral blindness in North America is ocular trauma related to sport, work, assaults, traffic, and contact lens-induced keratotitis. Sport-related eye injuries are the leading cause of blindness in school-age children in the United States. Current preventable strategies need to be implemented, including wearing safety glasses during dental hygiene care. Hearing impairment. 360 million people worldwide have a hearing disability. 360 million people worldwide have disabling hearing loss, and 32 million of those are children. 2 to 3 out of 1,000 children in the United States are born with a detectable level of hearing loss. 27.7 million American adults aged 20 to 69 years have hearing loss. When hearing is impaired to the extent that is no practical value for the purpose of spoken communication, a person is considered deaf. A person who cannot hear as well as someone with normal hearing is referred to as having hearing loss. Hard of hearing refers to people with mild, severe hearing loss who communicate through spoken language. The hearing loss can be mild to severe or profound and can have effect on one or both ears. Hearing aids benefit people who have sensory cell damage to the inner ear. Assistive measures and devices for those who are deaf or have hearing loss include qualified interpreters, assistive listening headsets, text telephone device readers, video text displays, hearing aids, and closed caption. People with significant hearing loss may benefit from cochlear implants. Causes of hearing impairment. The cause of hearing loss may be associated with the outer, middle, or inner ear mechanisms, singly or in combination. Many factors may contribute to the deafness. Congenital, prenatal infection in the mother, especially rubella, low birth weight, and birth asphyxia, lack of oxygen at birth. Inappropriate use of medications during pregnancy and severe jaundice in the neonatal period. Acquired. Chronic inner ear infections, infectious diseases, meningitis, injury to the head or ear, excessive noise, workplace and recreation, aging, and toxic effects of drugs will all have been implicated. Newborn screening. The spread of these universal programs prevents future psychosocial education and linguistic implications related to hearing loss. Partial deafness may not be diagnosed, or certain patients, particularly elderly ones, may not admit hearing limitation. Clues to identification of hearing problems include lack of attention, fails to respond to conversation, focus, strain, facial expression, or stares when others are talking. Turns head to one side, hearing may be good on one side only. Answers are unrelated to the question. Does one thing when told another. Frequently ask others to repeat what is said. An unusual speech quality. Access to oral health services. People with disabilities are the most underserved groups in receiving dental care, and we have the most significant oral health disparities of any group. Progress is being made to ensure adequate access to dental care, but barriers exist related to the patient's family, caregiver, guardians, and dental professionals. Having adequate access to dental and dental hygiene services can make a significant contribution to the oral health, well-being, independence, and sense of personal esteem of a patient with a disability. Although providing care for patients with disabilities is challenging, training, expensive, empathy, patience, and a desire to be successful can help. Trends to community-based delivery of services overview. Individuals with physical and intellectual impairments may be self-sufficient or may have community-based living, educational, and work arrangements. Barrier-free or assisted living housing for individuals and staff community-based residential facilities for group living are available for those who need daily assistance. Many home care and community-based services are available for individuals with disabilities. However, access to dental services is often limited by traditional office-based dental care delivery systems. New healthcare delivery system models are being proposed to provide access to dental services where people live, work, play, go to school, or receive other social services. Expansion of direct access. Regulations increase the ability of the dental hygienist to provide preventive services in alternative settings and functions as members of interprofessional patient care teams. Barrier-free environment. Healthcare facilities are required to follow guidelines and specifications for a barrier-free physical environment based on the ADA standards for accessible design. A barrier-free facility for a patient in a wheelchair who requires more space for turning and positioning is deemed accessible to all individuals. Additional features for other specific disabilities are braille floor indicators on elevators, doorways, steps, and stairways can be outlined with bright colors to contrast with the background for people with limited vision. External features, parking. A reserved area clearly marked near the building entrance and 13 feet wide, 8-foot car space with a 5-foot access aisle permits opening car doors for exiting and reboarding. Curb, ramps, cuts from the street and from the parking area. Walkways. A 3-foot wide walkway is needed for wheelchair accommodation. The surface is solid and non-slip without irregularities. Entrance. At least one entrance to the building on ground level accessible by a gentle sloping ramp, rise of 1 inch for every 12 inches. An easily grasped handrail, height 30 to 34 inches, is needed on both sides to accommodate left and right-handed cane and one crutch users. Door. The lightweight door with a lever type of handle opens at least 32 inches to accommodate a wheelchair. Internal features. Official regulations specify dimensions for accessibility of all aspects, including passageways, floors, drinking fountains, and restrooms. A few are described here. Passageways. Passageways must be at least 3 feet wide. Passageways must be free from obstructions such as hanging signs, chairs, and large plants. Floors. Level floors with non-slip surfaces. Movable rugs or mats are obstacles or hazards for patients who use wheelchairs, walkers, canes, or are blind. Reception area. Chairs should permit easy access during seating and rising. 18-inch high, flat, firm seats and arms to provide support when pushing oneself up by the arms. Should not slide or tip as the person rises. The treatment room. Doorways are at least 32 inches wide. Enough room beside the dental chair to allow for turning of the wheelchair. The dental chair is able to lower to 19 inches from the floor and accessible for both sides of the wheelchair transfer. An x-ray machine is in the same room, or a portable or handheld x-ray machine can simplify the problems of moving the patient in a separate radiography room. For the patient with visual impairment, move equipment such as a bracket tray and clinician stool from the pathway to the operatory chair and lower the chair before seating the patient. Risk assessment. Patients with disabilities may be at a higher risk for oral disease due to characteristics related to the specific disability or disease. Risk factors associated with specific disabilities and medical conditions are described in this book at a little later condition. Oral manifestations. People with disabilities have an increased risk for oral problems. Dental caries is common, often associated with diet and poor oral hygiene. Periodontal disease can occur more often and develop at an earlier age. Malocclusion is associated with muscular abnormalities, developmental delays, delayed tooth eruption, and oral habits such as bruxism and tongue thrusting. Oral and craniofacial anomalies may be present, particularly in individuals with developmental disabilities. Examples include enamel defects, high lip lines, and dry gingiva due to air exposure, variations in number, size, or shape of teeth, facial asymmetry and hypoplasia of the midfacial region, cleft lip or palate. Damaging oral habits can affect both soft and hard oral tissues. Examples include bruxism, food pouching, mouth breathing, tongue thrusting. Self-injurious behavior, rumination, regurgitation of chewed food, pica, eating unusual objects and substances such as cigarette butts or gravel. Evidence of trauma or injury may be present, especially in individuals with seizure disorders or physical disability. Weakness or paralysis of the facial muscles can compromise mastication and self-cleaning motion of the tongue. Food pouching is common. Drooling or impaired swallowing of saliva is common feature of some disabling conditions involved in the head and neck musculature. Potential oral side effects of medications includes increased dental caries risk due to sweetened elixirs or medication-induced xerostomia. Drug-induced gingival enlargement, a potential side effect of treatment with phenytoin or other anti-epileptic medication. Oral ulcerations, mucositis, and susceptibility to infection and frequent manifestations following chemotherapy, cancer treatment, or radiation to head and neck area. Functional ability. Functional ability refers to the ability of an individual to accomplish daily living skills, bathing, toothbrushing, dressing, answering the phone. In children, functional ability may also include activities such as coloring a picture or catching a ball. Assessment of functional ability determines what oral self-care task an individual can do alone, what range of degree of assistance is needed, or whether the person depends on others for complete care. An individual patient's functional level may be affected by decrease in cognitive capability, behavioral problems, mobility problems, uncontrolled body movements. Sensory impairments may mask a child's functional and intellectual capacity because responses may differ from other children. Children with blindness are limited in terms of learning by imitation. A child with blindness may learn to speak later than a child with average vision and may start school later. The earlier the hearing loss in a child, the more serious impact on the child's development. Communication delays may impact on social interactions and vocational choices. Medical status. Assistance in completing the health history questionnaire may be needed, especially for individuals with visual impairment. Specific details of the patient's limitations are recorded so that adaptations can be made during the current and future appointments. Having extensive knowledge of every health condition patients have is possible. However, having the knowledge about when to gather and apply additional information is essential. Assessment and monitoring of the patient's medical status during treatment can reduce the risk of medical emergency. Individuals with a disability may also experience additional medical comorbidities and health challenges such as cardiac disorders, gastroesophageal reflux, seizures, visual and hearing impairments, and latex allergies due to spina bifida or frequent surgeries. Medications the patient takes may enhance risk for oral disease. Medications with the side effect of xerostomia contribute to dental caries. Medications that diminish appetite as a side effect influence eating on adequate diet. Sucrose-based liquid medications contribute to dental caries incidence. Oral disease prevention and control. The objective. Whether care is being delivered in a traditional or an alternative practice, the dental hygienist's objectives are to provide regular professional examination and treatment at appropriate intervals to maintain patients' oral health, to determine patients' ability for oral health, self-care, and need for caregiver intervention. Motivate the patient and caregiver to establish and maintain healthy oral tissue. Contribute to the patient's general health through preventing tooth loss, thus maintaining ability to masticate food. Preventing malnutrition and increasing resistance to infection. Prevent extensive dental and periodontal treatment the patient may not tolerate because of lowered physical stamina or the inability to cooperate. Prevent the need for dentures or other removable prostheses which can be hazardous, difficult, or impossible for certain patients to tolerate. Preventive care introduction. Preventive interventions are selected based on individualized risk factors and level of assistance needed for daily oral care. Depending on the disability and level of function, the patient may need to complete assistance, partial assistance, no assistance with daily biofilm removal. Daily personal oral hygiene can be compromised due to patient or caregiver. Lack of knowledge and understanding about oral disease prevention and how it is accomplished. Lack of motivation to carry out the necessary daily routines. Lack of the necessary cognitive and physical coordination to carry out oral hygiene measures. Dental biofilm removal. Provide basic information. Individualized instruction is provided for each patient according to the patient's unique needs and functional ability. Determine the current daily care routine to identify if modifications are required. Biofilm formation and disease development are described on a level at which the patient and caregiver can learn and be motivated. Approaches for motivating the patient or caregiver health behavior changes should be learned. Toothbrushing. Basic information about toothbrushes and methods should be included. Provide clear and concise instruction. Biofilm removal is more important than the specific technique used, as long as damage is not done to the gingiva or the teeth. Use of a soft toothbrush and a scrub brush or circular phones method may be appropriate and within the capability of certain patients. Alternative positions for a parent or caregiver providing toothbrushing assistance are described more completely later in this chapter. Encourage independence in daily oral care. Although a caregiver may be willing to brush the patient's teeth, as much as possible should be carried out by the patient. Adaptations for brush handles and other oral self-care aids can promote or make possible a patient's independent biofilm removal. Demonstrate toothbrushing in the patient's mouth and describe the feeling of the filament tips on and under the gingival margin and the feeling of the clean teeth. Guide patient with hand-over-hand toothbrush technique to help the placement of the toothbrush in the mouth. Adaptive aids. For patients whose main deterrent to oral care, self-care is related to grasp, manipulation, or control of toothbrush, adaptations and self-care aids can help accommodate specific needs. Benefits to the patient may include feelings of self-esteem and accomplishment when able to manage the important task of brushing, particularly for patients who have physical but no cognitive disability. General prerequisites for self-care aids includes disinfectable, durable, can withstand exposure to water and saliva, resistant to absorption or oral fluids, replaceable and inexpensive. Adapted manual toothbrush. This attachment is useful for a patient with fingers permanently fixed in a fist who cannot grasp and hold. It aids to enlarge the diameter of the handle of an oral care implement, useful for a patient with limited hand closure. This basically you insert and hold the brush handle against the patient's hand. For the patient with limited shoulder or elbow movement, lengthen handle of the brush using a material strong or rigid enough to provide sufficient lateral pressure to remove biofilm from the tooth surface. Examples include attach a handle of a kitchen utensil, such as wooden spoon, to the brush handle with glue or tape. Tongue depressors taped to the brush handle, then one or two other tongue depressors taped to overlap and provide extension. Use other means by wrapping the object securely to the brush handle for elongation. A specifically designed toothbrush curved outer filaments and short, stiff center row of filaments that brush exposed tooth surfaces simultaneously is shown in one of the figures. For a patient who can hold and position the toothbrush but cannot make strokes for biofilm removal. For a patient who, with hand tremors such as with Parkinson's disease, can be used with patients moving their head side to side and up and down instead of moving their hand. Can be used by a caregiver who provides toothbrushing assistance. Provides similar reduction in biofilm compared with the use of conventional brush. Power-aided devices. Use of a power toothbrush can provide independence and more effective biofilm removal for many patients and can motivate patients who have difficulty with a manual toothbrush. Can cause trauma if used incorrectly, but for example, a patient unable to hold the heavier weight of the power toothbrush or one lacking the comprehension for the proper use. The extra size and weight of the handle may be advantageous for some patients or difficult for others with limited strength. The on-off mechanism may be difficult to use for those lacking finger strength and coordination. The larger handle can aid those who have difficulty grasping objects. The vibrations created during use cannot be tolerated by certain patients. Additionally, cost of the toothbrush may be a consideration for some patients. Additional power-aided devices such as flossers are available and are recommended based on assessment of individuals' patient needs and abilities. Patients are instructed to follow manufacturer's instructions for proper use as indicated on each package. A patient with limited grasp can adapt a cuff around the handle to aid in holding the power-aided brush, similar to those shown in the figures in the book. Cross-contamination can be a problem, particularly in group living situations. Ensure each patient has a separate marked toothbrush and is kept apart from others. Dentifrice. A dentifrice containing fluoride is recommended for patients who can use dentifrice. When a patient cannot control saliva, rinse, or expectorate, use of a dentifrice may be contraindicated. A dentifrice may increase a gag reflex for certain patients. When a parent or other caregiver is assisting, the paste may limit visibility for thorough biofilm removal. When a paste is used, only a small pea-sized amount is placed on the brush. Dentifrice is not essential for biofilm removal, and another method of daily fluoride application may be more appropriate. The person who is severely disabled may be treated with a suction brush, and that helps to prevent aspiration. Interdental cleaning. If standard use of dental floss is not possible due to limited dexterity or use of only one hand, the use of floss holder or other interdental aid can make interdental cleaning possible. Certain aids may be useful for the caregiver. Methods for increasing the size of the toothbrush handle may be adapted for the handle or the floss holder. Some patients will need to use other interdental aids. Careful instruction for use and supervision are provided to prevent tissue damage. Cleaning removable dental prosthesis. For the patient with difficulty grasping or holding the brush, a denture brush handle may be adapted by any of the methods described for the regular toothbrush. A fingernail brush may be used instead of a standard denture brush, provided all denture surfaces can be reached for biofilm removal. For the patient with use of only one hand or who needs to grasp the denture with two hands to prevent accidents, the following are recommended. Fingernail brush with suction cup, denture brush with suction cup. Can attach low inside the sink bowl as well. Fluorides. Selection of fluoride program for any patient depends on the assessment of the individual's caries risk status. The patient with a disability may be at an increased risk for caries due to barriers that limit access to preventive services, decreased ability to provide or cooperate with assistance for self-care, and the side effect of medications. Risk-based fluoride recommendations are described later in a different chapter. Encouragement to drink fluoridated tap water where available. Use of dentifrice fluoride. Dietary supplements for young children when fluoride is below optimum level in the community water supply. Some patients with disabilities cannot tolerate fluoride trays. Fluoride varnishes are tolerated better than fluoride trays for many people with disabilities. Fluoride varnish treatment is quick. Teeth do not need to be isolated, and the varnish is not sensitive to moisture. Self-applied home fluoride. For a dependent, low-functioning person, brushing with a fluoride gel rather than a toothpaste can be recommended, or the toothbrush could be soaked in fluoridated mouth rinse before brushing. Silver diamine fluoride is beneficial for patients with disabilities, as it is non-invasive and can reduce the need for surgical restorative work. Pit and fissure sealants. Pit and fissure sealants can be provided for cooperative patients with developmental disabilities with satisfactory results. Use of dental assistant is imperative to help the patient management and to maintain a dry field to ensure sealant retention. Use of a rubber dam is helpful for a patient with excess saliva, hyperactivity of the tongue, or other management difficulties. When a patient who is severely disabled receives general anesthesia for restorative procedures, pit and fissure sealants are placed in all non-carious occlusal pits and fissures at that time. Diet instruction, eating habits. Current eating and snack habits, extent of oral health knowledge, family customs, and economic status are considered before specific dietary recommendations are made. Difficulty of food preparation and dependence on others for grocery shopping can be a major limitation to diet selection for some adults with disabilities. Sweets are sometimes used as rewards or bribes by unsuspecting family members or teachers. Used applied behavior analysis, ABA, as a teaching tool. And the introduction of sugarless snacks and non-food as rewards and teaching tools is especially important. When a patient is high functioning, the parent, advocate, or caregiver may be able to keep a food diary. With the aid of the daily food record and information from the medical and dental histories, selected items for counseling may be selected that is caries. Oral factors. Problems with mastication and swallowing can lead to the use of soft diet, often composed mainly of carbs. Conditions affecting the integrity of facial musculature can compromise self-cleansing of the oral structure and contribute to food pouching in the buccal vestibule. Recommendations. General procedures for dietary assessment and counseling. Adaptations involve long-range planning for gradual modifications of the patient's diet. The person who selects and prepares the food for patient is involved in the planning. In an institutional setting, the dental hygienist can work as a member of the interprofessional patient care team with the administrative and medical personnel, teachers, dietitians, and aides to introduce dietary modifications. Patient management. With a few modifications and attention to managing specific factors related to each individual situation, most patients with disabilities can be treated in a clinical setting. Only a relatively small number of patients need hospitalization due to difficulties in management or systemic condition that require special medical supervision. The objectives: increase the efficacy, efficiency, and safety of the dental and dental hygiene treatment. Make patient appointment pleasant and comfortable. Modes of communication. Basic behavioral support strategies such as tell, show, do, modeling, positive reinforcement, and desensitization can be adapted to address the unique needs of the patient with a disability. Unless the patient has an extreme cognitive impairment, the patient is always addressed first and then the caregiver second. Address the patient in person first language, describing them by their ability rather than labeling them by their disability. Parents and or caregivers can explain how best to communicate with the patient, help interpret the changing moods of the patient, identify problems, and note changes in behavior that may indicate a dental problem. Using nonverbal communication, facial expressions, pointing, body language, and demonstration helps certain patients to respond. Kindness, patience, and empathy with help the clinician build trust. A person who is totally blind is more likely to accept a new experience if told about it in detail beforehand. A person with a hearing loss may prefer a particular way of communication. Choices include speaking, speech reading, writing, manual, or combination. Manual communication includes using sign language or signing and finger spelling. Always ask the patient which means of communication is preferred and how communication can be improved. American Sign Language. American Sign Language, or ASL, is a visual gestural language with a unique grammar and syntax. Many people with deafness who prefer this mode of communication grew up using ASL and consider themselves part of the cultural group. Individuals who have become deaf in later years may learn sign language and use the signs in English word order, meaning the subject comes before the word and the verb comes before the object in a sentence structure. Some people with deafness prefer to communicate using ASL in medical or dental situations. They can request the services of an ASL interpreter. A universal sign language has not been recognized, and many countries have their own. American Manual Alphabet. Finger spelling in the air is often combined with sign language. When making an introduction, for example, the name may be fingerspelled. New words often do not have signs and are fingerspelled. Oral communication. Oral communication by a person with deafness or severe hearing impairment may require a combination of speech, residual hearing, and speech reading. Speech reading. It consists of recognizing spoken words by watching the lips, face, and gestures. Many of the mouth movements for spoken words have the same appearance as one or more other words, so speech reading may need to be combined with another method of communication. Speech reading is not a reliable means of communication for extended, complex discussions for most people with hearing loss. Speech reading is not a choice when the clinician must wear a mask. Writing. Writing may be an alternative when the patient is hard of hearing or when other methods are not satisfactory. Having a writing pad available with pen and pencil for communication purposes. Pretreatment planning. Preliminary contact. Information may be obtained from the patient or with legal authority from the guardian, parent, relative, advocate, or other person responsible for the patient. The essential information can be obtained in advance by telephone interview. Medical forms can be mailed to the home for completion. Advanced information permits the dental team to be prepared to make the appointment a successful and positive experience for the patient and clinician. Legal guardianship. When a person is declared incapacitated by a legal process, a guardian is appointed. Documented proof of legal guardianship is kept in the patient record. When the patient is unable to sign informed consent for treatment, the legal guardian provides this service. Information to obtain. In addition to usual topics covered by the medical personnel and dental histories, there are other informations that must be obtained. To avoid unpleasant situations and misunderstandings, ask direct questions about a patient's disability rather than making assumptions. Consultation and interprofessional care team. Management of a patient with disabilities can be very complex due to medical complications. Need to prevent aggravating a medical condition while rendering care. Consultation with physicians, social workers, and other medical providers who form the patient's interprofessional care team may be required to help determine an oral health plan. Extra time may be required to access information about the conditions and medications before an appointment. Interaction with the caregiver. A patient with a disability may depend on a caregiver for daily life activities. Caregivers may or may not be the legal guardian of the patient or the contact person to plan appointments. If the caregiver is not the legal guardian, the adult patient or guardian must be consulted to determine the limits of the caregiver's roles. Caregivers can be excellent sources of information, help prepare the patient for the appointment, and offer suggestions for gaining cooperation from the patient. Invite the caregiver to the office before the appointment to see the facility and become familiar with the surrounding staff. Appointment scheduling. Special requirements. Allow time in the schedule for preparation needed before an appointment. For example, to move furniture, retrieve and set up special equipment, such as paper to write on for a patient with a hearing impairment, or to pre-medicate the patient. Identify special aids the patient is asking to bring to the appointment, such as a transfer board for transfer into the dental chair, hearing aid, dental prosthesis, and biofilm control devices currently in use. Individuals who are deaf may require an ASL interpreter. Some individuals with disabilities are accompanied by service dogs, such as a guide dog for visual, hearing, and other disabilities, which are allowed by law into all public buildings and on public transportation. When a patient brings a guide dog to the appointment, do not distract a dog on duty by touching, speaking, or making eye contact. Do not walk on the dog's left side, which can distract the dog. Do not offer the dog food. Do not lead or grab the patient while the dog is guiding. Ask the patient where the best place would be for the dog to stay during the appointment. Service dogs are well-trained animals and will lie quietly as directed by the patient. If you want to pet the dog, ask the guide dog user first. Often the user will remove the harness before allowing someone to pet the dog. Transportation. A patient may rely on the caregiver or another source for transportation to an appointment. A patient using a wheelchair may need to receive wheelchair accessibility, transportation, and be limited by the availability of the transportation. The transportation service may need to be contacted when the patient has completed the appointment forms, may need to be completed. Time considerations. Determine how the patient's daily schedule influences time selection for scheduling appointments. Inquire about the schedule of the caregiver who accompanies the patient. The cooperation of the patient may be decreased if the basic routines are disturbed. Arrange a time when the patient will not have a long wait. Allow sufficient time so that the patient is not rushed. Consider incontinence issues, including time needed for restroom visits. Patient reception, the initial appointment. The orientation of the patient with a disability paves the way for long-term success for dental and dental hygiene supervision and care. The first appointment includes, and when necessary, may be devoted entirely to a basic orientation to the facilities in the dental chair and personnel. Several orientation visits may be necessary to acclimate the patient to surroundings and to desensitize. Desensitization techniques and a show-tell-do approach can help reduce anxiety, particularly for a patient with cognitive impairment or one who is fearful. Assessment procedures and preventive personal care instructions are initiated, and participation of the caregiver is solicited as indicated. Introduction of clinical settings. Create a casual and relaxed environment. Create unique ways to communicate during treatment. Explaining the procedure step by step. Always face the person when explaining the clinical procedures. Describe each step in detail before proceeding. Introduce the patient to the dental office by utilizing their senses. Start the oral examination slowly. Use fingers first before introducing instruments. Explain instrument materials and how each will be applied using a show-tell-do approach. Prepare patient for power-driven instruments and avoid surprise application of compressed air, water from syringe, or power-driven instruments. Explain to patient the sound of the suction before turning it on for the procedure. For a patient who is not familiar with dental procedures, permit patient to handle dull or blunted instruments if able to do so safely. Allow the patient to hear the equipment, such as a saliva ejector, that will be used during the appointment. Introduce unusual smells or taste utilized during the different appointment. Apply rubber cup to person's finger so they can experience how polishing feels. A patient with a visual impairment. Because of the visual impairment, the patient may tend to rely more on their senses, such as touch and hearing. A person with total blindness tries to be neat and orderly. Avoid moving items belonging to a visually impaired person without altering them. A person who is totally blind learns to interpret and rely on tone voice more than persons with sight, who can watch facial expressions. Protective eyewear. The patient may prefer to wear the person's personal glasses regular warm. Light. Avoid directing the dental light in the patient's eyes. Sensitivity to light is characteristic of many eye conditions. Position the patient for best vision. For example, a patient with glaucoma has no peripheral vision. Thus, instruction may be given directly from in front of the patient. Do not expect a patient to see fine details such as that in a radiograph without enlargement. When the dental hygienist leaves the treatment room during the appointment, explain absence to prevent embarrassment of the patient speaking to someone who is not present. For the patient with a visual impairment, ask their preference for how to guide them to the dental chair. Many prefer to hold the clinician's arm and to follow them. Provide forewarning of potential hazards in the way. Patient with a hearing impairment. Full visibility is essential for communicating with a hearing impaired or deaf patient. Remove mask when talking. Wear a clear face shield. Do not demonstrate out of the patient's field of view. Be careful not to touch a hearing aid when it is turned on. Adjust patient's head so ears are not compressed against the headrest or pillow, which can cause discomfort. Eliminate or minimize background noise. And explain procedures. Continuing care appointments. The frequency of continuing care appointments for all patients is individualized, but frequent appointments are encouraged for some persons with disabilities. Assistance for the patient who is ambulatory. A patient who walks with one or more assistive aids, such as braces, a cane, or a walker. Certain patients do better without assistance because they have developed their own method of balancing. Many patients gain balancing by holding both hands on the partially flexed forearm or of a person walking beside them. Seating the patient. Ask the patient how much and what kind of assistance is needed. Raise chair slightly above the knee level and adjust the chair arm out of the way. Stand aside or assist while patient moves until back of legs touch chair and then bend knees to lower into dental chair. If assistance is needed, grasp ankles, lift legs, and turn patient into the dental chair. Remove assistive aids and store out of the way. For patients who are blind, have the patient feel the chair, especially the seat on the back, the seated patient. After telling the patient, tilt the chair back slowly. While tipping the chair back, place one hand on the patient's shoulder to offer assurance and support. Bring the feet up first to provide balance so that the patient cannot fall. If necessary, position supporting paddling to maintain patient comfort. Rising the chair. After telling the patient, slowly raise the chair to upright position with the seat slightly higher than the patient's knee level to minimize knee-to-knee bend their knees when rising. Allow time for adjustment to upright position in order to avoid the effect of postural hypertension. Ask or assist patient with moving their feet to the floor. Retrieve assistive aids and hold them for the patient to grasp with the dominant hand. Patient positioning. The objective for the patient positioning during treatments are to let the patient feel comfortable while the clinician provides care in a position that provides adequate elimination, visibility, and accessibility. Adapt chair positions. A patient with a respiratory or cardiac complication is positioned with the chair back raised to a level that is comfortable for the patient. The patient may be asked, how many pillows do you use at night? And the chair can be adjusted accordingly. Body adjustments. Patients with spinal cord injuries do a push-up, and patients with quadriplegia shift their weight every 20 minutes, 10 to 15 seconds to maintain good circulation in the tissue that do not have sensation, such as the buttocks. Allowing movement prevents decubitus ulcers. This is a particular consideration during long procedures. Place the patient in the center of the chair. Do not move limbs into unnatural positions. Allow the patient to settle into a comfortable position. Place patient's chin in a neutral or downward position. Supportive and protective stabilization. Always obtain a signed, informed consent for a patient, guardian, or parent before any form of stabilization is performed. Protective stabilization or medical immobilization techniques described below can help prevent injury to the patient, the caregiver, and the dental practitioner. However, the use of restraint is controversial and has risk of causing injury and resulting in legal actions. The method of stabilization is decided after communication-based or desensitizing techniques are tried and is individualized for each patient. When the patient is a child, the parent should be present to recognize immobilization protects their child from harm. Extremity movement. A team member, parent, or caregiver employs a hand guarding or hold the patient's hand. In hand guarding is unsuccessful, wrist restraints may be used, seat belts, Velcro straps, body enclosure. Although a small patient may be held by a parent, such positioning can be tiring for the parent, insecure, and may not provide good body mechanisms for the clinician. PD wrap or papoose board is an adjustable arm or leg immobilizer wraps with Velcro closures or padded board with wide fabric wraps around the upper body, middle body, and legs are available in adult and pediatric sizes, but not recommended unless the clinician has specialized training and informed consent. Head stabilization, arm of clinician. From a working position, a 12 o'clock, top of the patient's head, the non-dominant arm is placed around the patient's head to stabilize it in position. Head positioners or another person may also use stabilize the head. Oral stabilization. A mouth prop can be used to assist the patient who has difficulty maintaining an open mouth. The most stable mouth prop is sterilized ratchet type Molt mouth prop that can be nearly closed for insertion between the teeth. There are different types of rubber bite blocks. A long piece of dental floss can be tied through the holes in a commercially available rubber mouth prop, so in case of sudden emergency respiratory change, the prop can be quickly pulled out and breathing is normalized. Precautions for stabilization. Patient and caregivers are informed of the risk and reassured all stabilization devices are for comfort and to make the work easier, and they are in no way meant to hurt or punish the patient. Four-handed dentistry. The use of dental hygiene assistant during the appointment can enhance efficiency, patient management, patient safety, and discomfort. Safety and comfort for clinician, visibility during intraoral procedures. Instrumentation. Biofilm control instructions should precede scaling to reduce the bacterial load during instrumentation. Unbreakable mirrors are recommended for the use with the patient subject to spasms or sudden closure. Use single-end sharp instruments to prevent accidents. When an unrestrained patient moves involuntarily, the non-working end of the instrument can be a hazard. Use of power instruments is contraindicated for a patient at risk for aspiration and for patients who overreact to sensory stimuli, such as autism. Always do the show, tell, do. Finger rest. Firm, dependable finger rests are needed. Supplemental or reinforced rest can contribute to instrument stability. The occurrence of generalized heavy calculus deposits in patients with disabilities is not useful due to factors related to disabling conditions. Pain and anxiety control. General anesthesia delivered in hospital, surgery centers, or dental offices provided by trained anesthesiologists.